Hello everybody, lovely to see you. I'm going to focus on leprosy because that's what I know most about, but I've been rounding up bugs of all sorts around Christchurch and Canterbury for many years, a whole lot of different ones, but now I've got to focus on leprosy. And I want to ask the question how we can eliminate leprosy from the Pacific. And you might be thinking, well, gee, I thought it had all been done. Problem is it hasn't quite been done. Now, Christchurch has a long history of associated history of trying to alleviate the problems of leprosy in the Pacific. So in 1939, Patrick Toomey, who was the founder of the Pacific Leprosy Foundation, was so appalled by the conditions in the Kongai, which is an island in the Fiji group, and the human toll that was taken, that he decided he was going to do something about it. Now, what he did was, essentially, was get the telephone book out and write to everybody in New Zealand asking for a donation. And it worked. And thousands of people did donate. Actually, it was a way we could do some crowdfunding, actually, David, for the university. So thousands of people did donate over the years and raised quite a lot of money. And you can see from here that the number of cases that were admitted onto Kongai started in the 1910s and sort of reached a peak in sort of the 1930s, 40s. And those are hundreds of cases along the side there, you see, for each year. And then it began to fall in the 1950s. So that was when dapsone was introduced. So it was a slowly bactericidal agent which allowed people to be discharged home back to back to Fiji. And then in the 1980s, we had a much more active set of antibiotics that came along, and we could really make people better a lot quicker. So I think, well, how come there's a problem still? Now, interestingly, that large burden of patients that you see represented there was primarily people from Fiji. Something like 40% of them were Indians who had been taken to Fiji as indentured labourers who worked in the sugar plantations, and 33% were Fijians. So over nearly 75% of them were for the island of Fiji. So the huge burden of disease was actually there in Fiji. Less than 6% of them were from other countries such as Kiribati. And yet when you look now, what do we find? We find that the burden of disease is in Kiribati. The centre of the disease is in a place called Bajo, which I'll show you a little bit more about in a minute. And there's none in Fiji. The only cases in Fiji are actually imported from Kiribati. There's none in Tonga. There's about 10 cases in Samoa a year, which is not very many. And the numbers in the Solomon Islands, we know it was at least 30 a year, but we think they're probably underdiagnosed because of infrastructural problems over there. So now the centre has moved from Fiji to Kiribati. So how did that come about? Now, you probably don't know anything much about Kiribati, so I've got you a map here. And it's hard for me to point out, but unless there's a pointer. But if you can look up there, you might just see it. There's rather small islands there, Kiribati, which is the former Gilbert Islands. And then it goes right across to Christmas Island, which you might be able to see there again. So they've got something like 10,000 square kilometres of ocean and about 800 square kilometres of land, which isn't very much when you think about it. There's 100,000 people living there. The main island is this one of Tarawa, which is up here on the right. And you can see there that Bajo is on the end there. That's where we're mainly talking about, but the whole of South Tarawa is the most populated island. And at Bairiki there, at one end is where the plane lands, and when you fly in there, you're jolly pleased to see after going 3 hours north of Fiji, you're very pleased to see this atoll appear out of the blue, and you go and land there, and it's about 40k from Bairiki out to Bajo. Okay, so that's just a little bit of background information. Now, the history of leprosy is really entwined with the social history of Kiribati. Just prior to World War II, there's about 30,000 people in the whole of the Gilbert and Ellice Islands. And then they were invaded by the Japanese. They became a British colony in 1916. Invaded by the Japanese in 1941, very soon after Pearl Harbor. And then they were invaded by the Americans. It was the first battle in World War II in which the Americans were trying to figure out how to land on an atoll and take it. And it was quite a shambles in lots of ways. The Americans bombarded Beijio, shown here, for 3 days with artillery from the ships and also bombs, and believed that nothing could survive. And people in the neighbouring islands could see the coconut palm fronds going vertically upwards as the bombs landed. They thought that no one could survive this, but actually the Japanese were well dug in, and there was quite a massacre of Marines as they tried to come ashore when they stuck out in the lagoon area. So in that stage, there was no one in Beijio, no one with leprosy. And I know there was no one with leprosy because the Japanese rounded them all up and executed them. Not only did they execute the people in Beijio with leprosy, but all the people in the other islands which they inhabited or took over. So since that time, Beijio's population has risen dramatically, and with it has been migration from a lot of the other islands, and with it has come leprosy. So Beijio is a very small place, and it contributes most of the cases of leprosy. And I've just got here a visual of the numbers of cases diagnosed from 1991 to 2016. You can see there the low number of cases. In 1997 there's a big spike, and I'll come back and tell you more about that in a wee while. In 1910 there was another spike where someone got interested and obviously diagnosed a backlog of cases, and then the Leprosy Foundations got heavily involved in 2015 and 16, and the number of cases has gone up with the interest that was being shown. Now here, if we can make it work, I have a little visual of the number of cases over time in Tarawa. Now you can see here we've got Beijio there with a nice big blob there where someone's taken some interest. Almost no cases, and then they start to appear when people have taken interest, and you see that blob at Beijio getting bigger, and you can see the blobs are getting bigger, and here we are 2015-16, and the number of cases getting larger again. I might just run that through again for you so you can have another quick look. For this, it's just illustrating the importance of Beijio as being the centre, the hub of leprosy in the Pacific area, really. So you can see there the number of cases appearing. And now this is all basically with passive case finding until we get to 2015 and 16. Now, why Beijio? Why has it been like that? Well, it's the only place with a deep water port. So after World War II, there'd been complete disruption of the area. The land ownership was not clear, and so people started migrating in there to the port because there's work. And the German government set up a merchant marine training scheme there, which attracted more young men into work. And the capital then, by Riki, was established, and of course it gradually created a whole momentum of migration into the area. So we have the first major sort of thing for factor for leprosy, which is crowding. Now we know there's ongoing transmission occurring. So this map is sort of showing the number of children as a proportion of those who have leprosy. And you can see there that those under 15 are a significant proportion overall. And down in Beijio there you see it's more than 25%. So of the cases, 25% or more amongst children. That means it is being spread, rapidly amongst that population group. And it's a key marker, quality marker of control. It's basically saying that leprosy is out of control in the Beijio area. Now, Beijio is a very small place. It's only 1.54 square kilometres. Now, that's just a bit smaller than Hagley Park. And there's 17,000 people living there, and not only do they live there, but they have to have their gardens and work and all the rest of it, and it's just a low-rise area. So we know that Singapore, for example, has around about 7,500 people per square kilometre, but that's sort of high-rise, with lots of people living in high buildings. And in the Netherlands, the rate for the country is around about 700. So here we've got 17,000 people living 1.54 square kilometres. So this is a very crowded, very poor area. Average income about $1,800 per annum. And there's lots of chance for people to interact, obviously. Number of people per household is about 8, and for the rest of Kiribati, 7 or 6. For South Tarawa, it's about 7, and for the rest of Kiribati, about 6 per household. Now, leprosy is a very interesting disease. It's a relation of tuberculosis, and it basically infects through the nose, and it infects in areas where it's generally speaking, it's a bit cooler, and then it goes through the bloodstream and will go to other areas, such as this little girl. Now, these are images from WHO where full consent and things have been obtained. And you see she's got this little white patch on her cheek. Now, that patch will be anaesthetic because the organism damages the nerves as well. And some of them can be, copper-coloured or raised. And you see some of these are in areas where you might cover them up, so on the back or on the arm and so on. In the more invasive form, the so-called lepromatous form, you get a lot more organisms and often raised patches. And they tend to go to the mid-face, where the primary infection is occurring in the nose, and destroy the nose. And they also go to cool areas such as the earlobe. So the classic place to go and look for these organisms is actually in the earlobe. You can get complications with both forms of the disease, and it's because of the involvement of the nerves. You may get a wrist drop, so you obviously can't work. If you can't feel in your feet, then you may get ulcers. And of course, here's an example of the nerve being enlarged. After you start treatment, then sometimes the immune system wakes up, and you get these dreadful reactions which may go on for years, even though the bugs are dead. And that requires often a bit of treatment to check whether or not, with things like steroids, to try and dampen down the immune system. Now, I brought along my thermometer here because I thought we'd just check to see whether David Murdoch might be actually susceptible to get leprosy. So that says that's 22.5 degrees C. So I thought I'd just check David's ear and see whether or not what temperature that was, which is 29.1. So that's quite a bit cooler. Normally, if you just open your mouth here, David, see, he's actually 35 there. Now, if I measure inside my nose, which I did several times today, it's actually a couple of degrees cooler than what it is. And if I breathe out, breathe in, it's quite cool, and I breathe out, it's quite warm. So the bugs like to go to this nice sort of cool area. We could check your nose as well if you like, Kiki. I don't know where. What's your ear doing here? Maybe you're nervous and you don't. Let's see. He's obviously a bit nervous because he's 31 there, but that's still pretty cool. Okay. So there's this peculiar biology whereby the organism likes to multiply in these cool areas. Okay. So now there's one of the issues is because there's so much migration in Kiribati, we've got to kind of think about how we're going to deal with that. And this is images just to demonstrate the degree of migration in Kiribati. So the blue here is actually the number of migrants. These are people diagnosed with leprosy and say they come from another island. Their home island is somewhere else. And you can see that actually this other place called Bukenabu down here as well, near that elbow of the island, has got a very high number of migrants as well. So we've got continuing migrants coming into the area. And this image here basically shows some of the outer islands. And you can see on the outer islands, they're basically all red. They have leprosy, they stay at home. Whereas in Tarawa, you're getting this migration into the area. So migration is a big issue. So if we could eliminate it from the Beijing area, we've got to be careful because we like to see migration. And the conditions for leprosy transmission are persisting. Now, we've got some tools at our disposal which are a little better than was done previously. And these tools really consist of not only giving treatment for multi-drug treatment for people, but also giving prophylaxis. The big problem is that when you treat people, it only treats disease after it's been diagnosed. Now, there's a long lead-in period. A lead-in period from when they're infected to when they get clinical disease, and during that period you can transmit it. And then there's a period from the time in which you get clinical disease until you get diagnosed and treated. And that period can be quite long. Now, it's jolly hard to get accurate information as to how long that will be, because one of the issues is that people don't like the idea of having leprosy. It's got stigma, of course, as we all know. And stigma is associated with every culture around the world. And it's easy to understand why, isn't it? I mean, people get distortion of their mid-face, they get ulcers, their hands don't work, they can't support their families, they get into poverty, and become outcasts of society. And understandably, when you see someone as afflicted as that, you might feel that keeping them out of sight and maybe keeping them away from infecting you might be a good strategy. as obviously happened in the past. Now, we've got these new tools, which are to give antibiotics to people before they've got clinical disease. And there's been 2 big studies done with this. One in Indonesia, which showed that if you give the whole population 2 doses of rifampicin some months apart, then you can reduce the rate over the study period, which is about 4 years, by about 60 to 70%. And another study done in Bangladesh, if you give it just to people who are in the same household, then you can reduce the rate substantially as well in that range. Now, if you're a blood relative, you're much more susceptible to getting leprosy because you have the right genetic makeup to make you susceptible to leprosy. Whereas if you're just a casual contact, you seem to have less chance, but a single dose seems to work well. Perhaps your genetics are working with you. And the genetics are really important. We know from twin studies that monozygotic twins tend to have the same manifestations of leprosy, whereas digozygotic twins tend to vary between the lepromatous form, that's with all those bugs and the nasty destruction of the face and so on, or the tuberculoid form, which is just usually patches of anaesthesia on the skin. So, we've got these populations at risk. We've got the population there, you see with that little crosshatch, which is really representing the household contacts. And this might be 10 people in the household. And you can see there, there's a small population, so the numbers are small, but the risk is very high. Now, we can give prophylaxis to those ones, but you can see that only a small number of people are likely to benefit. Whereas if we have a lower risk, but significant risk, in this vast population on the left. And so, if we could treat all those, many of whom will never get leprosy, because actually only 20% of people are susceptible. The rest of the population is genetically immune. If we give a single dose to them, then we'll have a much bigger effect on the overall population. So the question is, how do we try and balance those 2 things? Now, it turns out that single-dose prophylaxis has been tried in the past. As I mentioned before, back in 1996-97, it was tried for the whole population, and this was a fantastic experiment, public health intervention, that was done by Dr. Delarco. Now, Dr. Delarco and his team, WHO-backed team, went into Kiribati and examined the whole population. That was about 80,000 people. That's not a bad effort, is it, really? I mean, you've got to go around all these outer islands, of which is about 20, screen the population and treat all those who were there. He found the highest population of leprosy patients was down in that Beijing area that I mentioned before. So examined all them again, then treated everybody, and then he got the whole population and gave them all a dose of rifampicin and a couple of other antibiotics. Now you can see there after 1997 the number of cases comes down, and he probably had quite a big hit on the numbers of cases. Where he identified these ones in 1996-97 was the backlot of undiagnosed cases really, and then it comes down. And then of course you can see it comes up and goes away, and we have a lot more cases reappearing. So we want to try and avoid this pitfall. So what went wrong? Well, what really went wrong was that Dr. Delarco died. And he was a Fijian doctor, and his wife was Gilbertese, and he spoke the language, and he had great sort of mana within the population there, and was able to mobilise people in this public health initiative. And when he died, of course, the number of cases went down, and then you start to get this loss of expertise about it, number one, and secondly, everyone gets a little bit blasé and think, well, it's not becoming an issue really. So one of the questions is, well, did he have a plan B anyway? And I don't know whether he did or not. I'm not sure he really knew what he was going to do next. He did a fantastic job, and I'd like to write an article sort of in praise of Dr. Delarco, really. But you know, we need some more information. We need better tools about knowing what to do next. How many times should we give prophylaxis? How far apart? Should we just focus on the mass chemoprophylaxis, or should we actually do something for the households as well? My intuition is that we should do both, and we should have an ongoing program around the household contacts, and we should do mass chemoprophylaxis. That's about 110,000 people. When I broached this with the Secretary for Health just recently, he said, we do mass chemoprophylaxis, we've done it for filariasis and we've done it for trachoma, maybe we can do it for leprosy as well. But to try and get some better information around this, we've done two things. One is to get the mapping done, and I'm not sure whether Dr. Tyson is here. And secondly, so he's done that map, those maps that I showed you. So we get some idea of the distribution and the risk groups and so on. And secondly, we've got a collaboration going with the Erasmus Medical Centre. And they set up a mathematical model which we can apply to Kiribati. And we have a master's student who might or may not be here, Charlotte. And she's going to be going over to Rotterdam and work with them adapting the model. So we can start to ask the questions. What will happen if we give mass chemoprophylaxis? Should we do it again in a year or 2 years or whatever? How much effect will we have with the focused chemoprophylaxis approach? Now, we'd also like a better tool for treating those patients who are actually just at the brink of developing clinical disease. You can't identify them, but maybe we can tell they're high risk because of their blood relationship and heavy exposure. And we'd like a really better tool for dealing with those, because I think if we could deal with those, we'd have a great chance of eliminating leprosy from Kiribati. Now, we can't alter the risk factors. I mean, the major risk factors are crowding, and sort of a rural lifestyle, poverty. Those things require a lot of other things besides interventions at the medical level. Those are social changes. But I think that we have this combination of things we can do. I think people with public health expertise and motivation in the universities and commitment from the CDHB. Now, these clinics, which haven't really described properly, which were run in 2015 and 16, were clinics which were run with staff from Canterbury District Health Board and myself. We went up there together with Nabura, who I don't see here, who's a Kiribati doctor living in Christchurch. And the last one we did in 2016, we had a lot of interventions, a lot of interactions with the local people, so church leaders, women's groups, a lot of posters. With the guy who's Kiribati's Got Talent winner, he sang a song, and it got a lot of acceptance and provided another way of people who are worried about having leprosy to get into the medical system. We screened something like 900 people that day. Just found a large number of cases of leprosy, all of which were validated by a leprologist from WHO who comes with us. So that's a way of creating another bit of momentum, another way of getting into the system and trying to overcome the stigma, which is often a barrier to treatment. So I think with a combination of expertise that's available in the universities and the District Health Board, and with NGOs such as the Leprosy Foundation, we can start to make a bit of a dent in this. People with leprosy and any other infectious disease deserve all the human dignity we can give them, and deserve our care. And we've got a long history going back in our culture of having compassion towards people who are unwell, and I think we have a job we should be honouring that long-term ethical standard that's been with us for so long, and there's opportunities like this where we can exercise it. So with that, Kiki, from a very fine point of view, I think we're going to hand over to hear a big picture view. Is that right?
Thank you, Stephen. Enjoyed that. Good evening, people. I better just sort this out. I'm going to give you a overview of some perspectives about Pacific Partnership, and then give you some objectives about where I think we should be heading. And I'm going to drop down to a couple of areas that involves particularly the University of Otago and the Canterbury DHB, not so much at the high level, but actually with the clinicians within both the university and the Canterbury DHB, and their contributions as physicians and clinicians and academics into the Pacific. I don't want to dwell on Pacific within New Zealand because I think that's a privileged society where we actually have more finances, resources, all those sort of things. I want us to look at what we can contribute to the Pacific region or what they can contribute to us, and the particular focus actually looking at the workforce. So I look at this map, and I think the best thing to do is you go Google Map and sit in the highest satellite and look over the ocean and say, well, how can we share the knowledge, the love, and the education and the thought, so that when you actually see the darkness and switch a light, that there's equal lighting despite the sizes of the countries that comes out of the whole region. That's what we want to achieve in due course, despite the sovereign differences between the nations. Now, if we can do that to a certain extent, maybe not so bright in Kiribati because of all the TB. No, that's all right, Nabura. But, you know, we want that light to be as equal as possible. Just a reminder about the populations in the region. Papua New Guinea, 8,000, too many people, too difficult. They're just for the Australians to look after. Let's leave them up there. Let's come back down to the Southern Pacific, where we have Fiji, the biggest at 900,000, Solomons, and the variations of the middle countries around 100,000, the smaller ones at 10, 15,000, Cook Islands, Nauru, and then I'm not sure whether there's that many on Niue, but there might be some Niueans in the audience that'll give me a bit of grief. Now, the Pacific context is that there is about 22 different countries out there. So the Pacific is not one, we all know that. It's a bit like the North and South Island, isn't it? We're not quite the same, and we should be proud of that. And so, see, I'm speaking like a South Islander now. But in the Pacific context, the three big pillars of society is the church. The church is sitting to your left up there. The church, parliament, the tribal culture, and the community spirit. You cannot shift one without moving the other three or four. If you understand that, then life's actually quite simple. How you do that is another story. But remember that in the Pacific context. And then when we look at how do the Pacific people view health, and this is the UNICA Declaration, which has been reinforced and reinforced, and quite key and crucial to how the Pacific people actually look at health. And you read through that, and really, you know, the biggest point is that the ocean which sustains us is to be protected, and that's big time for everybody. This was developed in 1995 and has been the core key driver for most of the health sector initiatives in the region. And then I just wanted to bring up the health strategy for New Zealand and to remind us that until recently, the number 8, which I've highlighted there, is bringing back those big things that the Pacific people think about into our strategy, because it is big. We know this, but we don't actually articulate it as much as we do. So from the UNICA Declaration, the health ministers clearly felt that they needed a way of improving their health in certain areas, and part of that area was around specialist training and specialist treatment programs, because a lot of their money on individuals was spent sending people overseas. Think about liver transplants, cardiac surgery, cancer treatment, and all the list of things that go on. So in 1998 they set up a program called Postgraduate Training Program through a Masters of Medicine in Fiji, and this guy is a great colleague of mine. He's a brute of an orthopaedic surgeon, trained in Dunedin, so you can understand that. He finished off in Auckland. He's also a general surgeon by training, and he went back to Fiji and started the program in Fiji, which, with a host of other individuals and funded by Australia and New Zealand Aid, set about a postgraduate program similar to our fellowship programs we have in New Zealand and Australia in the areas of medicine, paediatrics, obstetrics and gynae, anaesthetics and surgery. And it was this time that a few of us happened to come back into Christchurch, and a few of us had these long-term visions about how to develop, how to share what we learn with our colleagues, and also and how they could also influence how we behaved in those environments and how they could contribute back to us. And from there the program progressed, and in that time I could see, as I was working in Fiji with him at that time to deliver paediatric surgery and also looking at how to grow the kids, as I call them, into the specialty areas. And given that I'm a surgeon, it's easier to pick up surgery and use that as a tool or as a guidance for others to actually work along. And And these programs then started to evolve, and we started to graduate some of the students through. And this slide is actually about what Christchurch has done. This is just Christchurch. The program involves Australia and New Zealand, by the way. We have programs in Dunedin. We have similar things in Palmerston North. We have Auckland. We have Middlemore. But specifically, I want to thank, and put this slide up really to thank Christchurch for the contribution, not just what Stephen Chambers is doing for the infectious disease. There are other multiple programs, but this is particularly what I have been involved with, and we've been driving to look at Christchurch as a vehicle for advanced training in all those specialties. And quite poignant that in the time of the earthquake, we had about eight surgical trainees here who actually stayed behind and looked after the place while a lot of people actually left. And interestingly, about 5 years later, the surgical department actually came together and said, we want to look after these particular kids, and we're going to formalize a training program for them. So if you look at orthopedics now, we have a rotation that's every 2 years a new trainee comes in. The current one from Fiji, the previous one from Vanuatu, and the previous one from Fiji. In terms of the anaesthetic program, it's been set up that there's a rotation through Fiji after their specialist training. They go to Hawke's Bay, they come then down to Christchurch, and they go and they return into their country of origin. So we have started earlier than that. We have had a cardiologist who is now, and then you will say, well, one of the questions that might come to your mind is, do they all go back? What happens to our trainees that come here? Do we lose them all into New Zealand and Australia? We rarely actually lose them at all, and I'll go through some of the slides later on, that in terms of brain drain and losing our kids to training, we don't actually think like that. And if you think about it in the audience or in training, we'd never say to our registrars who has suddenly got a position in Harvard or a position in Sloan Kettering, for example, or Oxford, when our trainees get a research position or some high academic position or clinical research position, we say to them, good on you, go for it. And I have the same philosophical approach to our kids from the Pacific. We should not temper what they should be able to achieve. And in fact, most of the ones who are very good will go and achieve that. And the ones who don't want to go and achieve that will just go back home and carry on and provide leadership in the special areas they have. So what did we do with the surgical program? Well, we had to make it sexy. That's the only word I can put it to that. And we had to make it sexy. We had to make it so that people wanted to come and join the program. A new initiative in 1998. Nobody had really set about to say how we're going to develop and evolve this. This medical school is older than Otago University. Medical School of Fiji was formed in 1885. And yet, this is a very delayed formation of the specialist program. So what did we do for a start? Well, we had people like Stu Gallen here coming out to help us train in neurology, picking up all these the senior surgeons who by default would have had a specialist attachment because they worked in that particular area for the years. So this is the grandfather clausing of specialists in the region. So we needed to have these surgeons on board because they were the leadership. Then we needed to attract the younger ones to come through. And Wanga on your left is actually the head of the school in general surgery, associate professor in Fiji, and he's one of our key leadership people there. On the right is Chitoko Thama, a fellowship in paediatric surgery. One of the lessons learned, we sent him back. He went back, tried hard, but because of the amount of pressure, I guess, on the system, and we didn't have enough mentorship, we didn't actually provide enough support for him. So in the discussions, he's now based in Waikato, and he supports the leave for the Fijian surgeons and goes back and forth. And in fact, he has a trainee from Fiji with him in Waikato. And then we have, I just put this slide up because we have a list of surgeons. So some of you may recognize, we don't just bring them from Fiji. Dixon Hansel has just recently returned to Samoa as a fully fledged consultant surgeon in the academic program. Waingalo was the orthopedic surgeon. He's now in Nandi, running the shop there. Rajiv has just returned as a urologist. She really was here as a urologist. Basil from Vanuatu is a general surgeon. Chitoko's in Waikato. And Maloney in the background is back in Fiji, also trained here in Palmerston North. And one of the things that I've always talked to our team about leadership in the Pacific, about health leadership, is not being a surgeon. It's actually being a consultant in a post, then you lead your country. So our discussions have actually led to things like, it's not good enough just to go back and be a surgeon. You might be better to go back and be the Minister of Health. Now, that's not good for the surgical fraternity because we run short. And in fact, that's actually come to roost because this one here is now the Minister of Health for Tonga. This one here, where is he? He's not here. There's another slide. There's another one who's probably going to be the Minister of Health for Vanuatu. And I wouldn't be surprised if this one and this one also become political in the environment, because that is where we look at the leadership. And as I say, this is the first push through. We're hoping for more numbers to come through, and then we'll hopefully have surgeons to keep working and do the surgical work rather than do the politics. There's always lessons to be learned with these sort of activities. There's pathways that come when the kids are coming through the program. Eli Bethy is an orthopedic surgeon who came through the program and had a different philosophical approach and couldn't actually tolerate working with his peers in Fiji, so he actually had to leave. In fact, I had to ask him to leave because they're all so nice to each other. And these two, Wanga is still there, and this is the time when the three of them, what a fantastic threesome they would have been in terms of delivering health services to their country. But the philosophical approach doesn't actually work when it comes to certain things about how they came into the system. There are ways of how we approach the training. It's very much an open training system. The way to engage is philosophically to say to everybody, we're sitting on the same platform, what do you want to do? So once they're in the master's program or wanting to enter the master's program, it's pretty much open that you move forward. Everybody knows what everybody's doing in that program. And so there is no secret messages, there is no capture for the positions within the program. It's all open, and certainly encourage them in activities like this to participate. And I must say it's been quite a satisfying process to take them through, watch them grow, and then have the ones coming through teaching the next generation of surgeons, and this is actually the next paediatric surgeon that's in Fiji at the moment, and the leadership here that we have on the ground. So in the last 5 years, all four surgeons have gone back to Vanuatu. They service the country, and that's all they need for about 200,000 people. Solomon Islands, similar deal. We're not worrying about the brain drain. The teams are going back home and working. The Samoans, not to be let down, have a big contingent. That was just a photo last year in their country where the training program is flourishing. They now want to establish an outreach, a regional training program based in Samoa, and I think we're going to move that in the other countries like Tonga. These are the Cook Islanders that I better put something up for them because otherwise they'll probably tell me off. But these are our specialists who are just finishing. Deacon's the surgeon who's finished the program. Terence is a physician who's just finished but will spend time in New Zealand. Tai is in Neathis, also finishing this year. And this young lady is going to be our next ONG physician. And on that program, I'm talking about at the ground level, I'm talking about the teachers, but also at the same time, we do punch at the highest level. So this is King Tupou VI in our last meeting in Tonga, not too long ago, with our president of our college and the Fijian, the Papua New Guinean president of their college, and Bill Tangi, who's the ex-Prime Minister of Tonga, Scott Stevenson, who we know is a ENT surgeon here. So the main outcomes about what we look at in terms of what do we do with what happens to these trainees that we bring across. Like I say, I've never really worried about the brain drain, and we think about more the brain rotation because our kids are actually all throughout the region. Some are in different countries. The pattern of overseas referral has changed. We now don't refer cases that we used to, like complex thyroids are no longer referred overseas. Some cancers are now treated locally. So there's a whole host of changes. The system's become sustainable because the previous trainees are now the bosses and running the system. And there's no doubt the long-term relationships are coming to fruition. The cardiology trainee is now the acting dean in Fiji, who now is in touch with David Murdoch, and hopefully they will move the relationships forward. Now, just 5 minutes, I'm going to run on a different line. This is more touting the University of Otago. So in the Cook Islands, well, I guess I should say I'm privileged to be born and raised there and all those sort of things. And the Cook Islands is about 800, 900 miles from north to south, population of about 15,000. And until recently, we've been training at the specialist level, those group of kids, and we've been trying to have a sustainable model where our higher levels are in place, and we've got people being trained and returning home. But more recently, we've realised that at the primary care level, that we don't have GPs who have career paths. So they're called outpatient doctors who are just left in the corner with no career path, or you might get sent off to another island with another career path. So in a sequence of events and through the Rural Hospital Medicine, the College of GPs, the University of Otago and the Ministry of Health Cook Islands, funded by New Zealand Aid, we set about setting up a local program called the Cook Islands Fellowship for General Practice. This is a Cook Island formed program that the Cook Island Ministry of Health award to their trainees, once they have completed a set of criteria, which is 6 papers through the University of Otago, a year placement in New Zealand, and then a series of attendances at conferences and presentations that we normally do when we're supervising them throughout their career, which spans over 3-4 years. And these are the first 2 graduates coming through. We have small numbers, and Liz is the Ministry of Health, and Pat is the chair for the Rural Hospital Medicine. Kati and I think that's Steve are the 2 that run the program. So with the program, I put this up because we had to get somebody over there sort of with a flag on, and it happened to be Richie Polton, and Richie was the one that awarded the certificates to some of the kids. But Peter Crampton has driven the agenda from a higher level to get this going, and so we've had the backing at the higher level all the time to put this in effect. And so the outcomes we're looking for, obviously, is making sure that, one, there is training that is actually supported by the College of GPs, by the Rural Hospital Medicine, and appropriate for the setting of the Cook Islands. And at the same time, they also go up the pay scale. Crucially important is why we set this up, is that they need to have accredited degrees or diplomas so that they can be recognised by their respective ministries, so that their pay levels can actually increase according to how much input they have. And that's the same with what we do in New Zealand. Now, the trade-off for setting up this program is that New Zealand actually have their own post in the Cook Islands for training of New Zealand doctors in the Rural Hospital Medicine. So that just started last year, and it's running now for another year. So it's a win-win situation for both teams. And of course, all the GPs and Rural Hospital Medicine people would want to go to the Cooks. Why wouldn't you? To go and work there and maybe have a bit of fun. And obviously, the final outcome is seeing the graduations for the programs. Success is when you get Peter Kempthorne on the dance floor, Roger Mulder. I'm not sure that's successful, Roger, but he'll pass for now. And Rob Corbett and a few others with our Minister of Health. Lessons learned. This is a group of surgeons who were trying to debate against the psychiatrists that mental health funding shouldn't be supported for mental health conditions. That really set them off. And not hard to see that the surgeons lost the debate. So back to my first comment. I think if we look at the Pacific and how we develop, how we evolve, I think it's fantastic with what has been happening in Christchurch, both from a clinical point of view and academic point of view, the relationships that's developed over the years to develop our trainees. And I think we've also learned quite a few things from our side, the New Zealand side, and then the opportunities to provide some of those higher level services, which some individuals do off their own bat, actually, as opposed to going through programs. And I really do believe we need to share more, because it doesn't actually cost much. And that's sharing across all levels, and hopefully the government will also do that one day and make it easier for all of us. Thank you.